studies who showed that mortality was more than doubled if you had hypoxia or hypotension. And so when a patient comes into my PICU with a traumatic brain injury, I do what everyone else here does. I speak to our neurosurgeons about putting an intracranial pressure monitor in. I put an invasive arterial line in so I can measure the mean arterial blood pressure, and then I can calculate the cerebral perfusion pressure. And then I refer to our hospital policies and look at which intracranial pressure I need to avoid and what cerebral perfusion pressure I need to maintain to make sure that my patient's brain is not becoming hypoxic. And by doing so, I'm absolutely sure that my patient's brain is not going to get hypoxic ischemic injury, or so I thought. So this slide is going to show you that cerebral hypoxia can still occur even when you have a normal intracranial pressure and a normal cerebral perfusion pressure. So this was a study done by Pat Kahanik's group in 2012 where they did brain tissue oxygen tracings and they paired them with intracranial pressure on the left and cerebral perfusion pressure on the right. This red arrow is pointing to a threshold of 20 for ICP and a cerebral perfusion pressure of 60, and they set their threshold at a brain tissue oxygen level of 30. And so this red arrow is pointing to the quadrant where cerebral hypoxia is still occurring despite a normal intracranial pressure. And this red arrow is pointing to the quadrant where there's cerebral hypoxia even though CPP is being maintained. In contrast, the blue dots represent the areas where there's intracranial hypertension and an inadequate cerebral perfusion pressure, and cerebral hypoxia is less common. These types of data have been replicated in the adult traumatic brain injury protocol, and so they're still showing us that we still have cerebral hypoxia. And that's probably why we've been unable to show in a clinical trial setting that intracranial pressure-guided management protocols actually improve outcome. And so we're left with this problem, cerebral hypoxia. We need a method or a device that's going to detect cerebral hypoxia, and we also want to, when we intervene on that data, make a difference to patient outcome. So over the time, we have been using some measures of brain oxygenation. There's jugular venous oxygen saturations. It's a global measure. It is bedside continuous. The problem with it is that it's invasive, and that's precluded its use in our paediatric population. So we've got near-infrared spectroscopy. It's non-invasive, continuous bedside. It's a more regional measure. A threshold of less than 45% for more than 3 hours is said to be associated with brain injury. It's more common in our cardiac patients, and it turns out that you don't actually need a pulse to get a NIRS reading, as this study is going to show you. So this was an observational study looking at NIRS in vegetables and comparing it to humans. And the vegetables have been de-identified to protect their identities. So we've got a butternut squash, a yellow zucchini, and a yam. And carrots had been included for study, but some of the authors ate them, and this was considered a protocol violation, and so they were excluded from further examination. And so the control subjects were cardiothoracic surgeons. They had to be neurologically intact, and they couldn't be vegans or fruitarians. And so this table is showing you their results, and they showed that the cardiothoracic surgeons and yellow zucchini have the same brain oxygen levels. And I don't really read too much into that, although the authors did say that one of the limitations of their study was using cardiothoracic surgeons as their control group because they often walk around in a state that mimics vegetation. So anyway, getting back to children, there's no evidence that intervening on NIRS actually improves outcome in children. And so we need a new monitor, and perhaps we've got it in something called a brain tissue oxygen tension monitor. This is the Lycox. It's been around for over 20 years. You've got a probe that you insert into the white matter of the brain, and then you get a reading on the box. The Neurovent by Raumedic has just been currently available on the market, but most of the studies in the literature have been using the Lycox, and that's probably the more superior device on the market. So what are the components? It's a double lumen catheter. The first one measures temperature and interparenchymal ICP. The second measures brain tissue oxygen tension. If you want an EVD, you need a separate catheter, but you can put that through the same drill hole. And then once it's inserted, you need to do an oxygen challenge to check probe function. You want to make sure that it's not malfunctioned or you haven't damaged it upon insertion. The limitations are that it measures a very small focal area of brain tissue oxygen tension around the probe. It takes approximately 2 hours to adapt to a stable reading, although there's slight drift with time and complications are rare. So what does the number on the box actually represent? Well, it's thought to represent the diffusion of dissolved plasma oxygen, which I'll explain. So the Fick principle describes blood flow to the brain, and Kishi and Schmidt adapted that principle to describe blood flow to the brain. And so this is their schematic. The light grey is blood flow, and the dark grey disc is the brain tissue itself. And they said that the amount of oxygen that crosses the blood-brain barrier is equal to the cerebral blood flow times the arteriovenous oxygen content difference. If you remember from med school, you can expand that equation to represent the 98% of oxygen that's dissolved that's bound to hemoglobin, and then the 2% in blue that's dissolved in plasma. And what they found was that they looked at each of these 4 variables, and what best approximated the number that they were getting on the box was actually the dissolved plasma oxygen with an R value of 0.86. So what are normal values? The largest series have been done in 25 patients where the mean value was found to be 23. And then what is the ischemic threshold? So the Brain Trauma Foundation published their guidelines 2 years ago where they said there was insufficient evidence to actually come up with a recommendation for a threshold. Looking at the literature, it's well recognised that if your number is less than 5, then you're probably going to die within the next 24 hours. This series showed that 4 out of 5 patients died when their levels were less than 5. Early studies used an ischemic threshold of 10 because that corresponded to a jugular venous oxygen saturation of less than 50%. And then the 2 most highly cited papers showed that if your level was less than 15 compared to 20, that you had an increased risk of death. And that corresponds with PET studies that show an ischemic threshold of 14. But you don't really want to wait until your level drops below 10 or 15 before you intervene because you may miss a window of opportunity to reverse brain injury, and so the reversible threshold is commonly set at 20. So where should we put the probe? This is hotly debated and there's no right answer. You can put it in normal appearing white matter in the less trauma-affected frontal lobe, but then it's going to be more of a global monitor and you may miss the area at highest risk, or you can put it in the penumbral area. Who should insert the probe? Well, we can't do it by ourselves. We need to get buy-in from our neurosurgeons, and so we can't really do it without their help. And then how should we use the number on the box? We can use it in 2 ways, as static index or as a dynamic index. Currently, there's insufficient evidence to support a recommendation for brain tissue oxygen monitoring at all, and it's because of this evidence table. So we've got 1 class 2 study in light blue, and then we've got 6 class 3 studies. There were a mix of retrospective and prospective cohorts, and you can see that the threshold most commonly used was 20, and I've colour-coded the outcomes where red is worse, blue is no difference, and yellow is an improved outcome, and it was really this mix of outcomes that led to the recommendations by the Brain Trauma Foundation. So this paper was published last year. It didn't form part of that table, and it's exciting news for the neurocritical care world. It was brain oxygen optimization in severe traumatic brain injury. It was a phase 2, 2-arm, single-blind, prospective, multi-centre randomised controlled trial in 10 ICUs in the States. It had 120 adults, and their hypothesis was that a management protocol informed by brain tissue oxygen tension and intracranial pressure would actually decrease the burden of cerebral hypoxia. Patients were randomised to ICP alone or ICP and brain tissue oxygen tension monitoring, and they used a threshold of 20. It was placed in the least trauma-affected frontal lobe. Control groups also had brain tissue oxygen probes. And then this treatment grid had 4 interventions. So type A was when your ICP was normal and so was your brain tissue oxygen tension, so no intervention was required. Type B was for isolated intracranial hypertension. Type C was for isolated brain tissue hypoxia. And then D was for both, and this is an example of the type C intervention to try and improve brain tissue oxygen tension. You had to use tier 1 before you moved on to tier 2. There are many protocols out there in the literature of how to improve brain tissue oxygen tension, but this is the only one that's been tested in a randomised controlled trial. So the study was found to be safe and feasible, and you can see that the intervention group had far less brain tissue hypoxia with all those zeros and the p-value there. And although it wasn't powered to look for outcome, mortality was different, with 34% in the ICP-only group and 25% in the intervention group, and good outcomes were also different. So you can use the number in a dynamic way, something called brain tissue oxygen reactivity, which may be helped to be a prediction tool in the first 24 hours after injury. So the science behind it is that you've got oxygen regulatory mechanisms in healthy brains, so that any rise in your PaO2 results in no change or a minimal rise in your brain tissue oxygen tension, in much the same way you get cerebral autoregulation. And so in the same way that you get loss of CO2 reactivity after severe traumatic brain injury, you may get a loss of oxygen regulation, so that if you get a rise in your PaO2, you'll also get a concurrent rise in your brain tissue oxygen tension level. So this paper looked at 46 adults. They had 120 tracings, and they increased the FiO2 to 1 for 15 minutes each day for 5 days. And they found that patients with a type A curve were more predictive of a favourable outcome. And you can see the plateau response there. So they had a rise in their PaO2, but a minimal rise in their brain tissue oxygen levels, indicating intact oxygen regulation. Patients with a type B or a type C curve had a poorer outcome. So the second way you can use this dynamically by the bedside could be something called brain tissue autoregulation. The variable is known as Oxygen Reactivity Index, or ORX, and it's the ability to maintain brain tissue oxygen levels despite a change in your cerebral perfusion pressure. And the hope with this is that you can identify the individual patient's cerebral perfusion pressure range at the bedside, in much the same way that PRX, or the Pressure Reactivity Index, is currently being used at the moment, which is a robust bedside measure of cerebral autoregulation. So just to explain a little bit, PRX is a moving Pearson's correlation coefficient between mean arterial pressure and intracranial pressure, and your values range between -1 and +1. So if you've got intact cerebral autoregulation, when you've got a rise in your mean arterial pressure, you get cerebral vasculature vasoconstriction, you get a drop in your cerebral blood flow, and then you get a decrease in your intracranial pressure. You've got a negative correlation between your MAP and your ICP, and so your PRX is -1. It's the opposite to what you think it should be. Conversely, when you've got impaired cerebral autoregulation, when you get a rise in your MAP, you also get a rise in your cerebral blood flow and a rise in your ICP. You've got a positive correlation between the two, and so your PRX is +1. If you plot PRX on the y-axis and cerebral perfusion pressure on the x-axis, then the nadir will represent where your value is most negative. In this example, it's 92.5. And so that's giving you a range of 80 to 100. And if you follow the Brain Trauma Foundation recommendations of 50 to 70, then that would render this particular patient ischemic. So this is showing you why it's so important to identify an individual's targets at the bedside. So when the investigators in Cambridge looked at this ORX variable in the hopes that we might be able to do something similar, they were disappointed because it was not correlated with PRX here, which gave you a nice U-shaped curve, but the ORX variable didn't give you that nadir. So it couldn't be used to predict patient outcome, and it couldn't be used to calculate that individual cerebral perfusion pressure. So before we add brain tissue oxygen monitoring to an already crowded bed space, we need more information. We've got Boost 3 that's following on from Boost 2, and then we've got an ANZICS clinical trial group study called Bonanza, which is brain oxygen neuromonitoring in Australia and New Zealand assessment, that's currently got funding for 4 to 5 adult sites to start in Australia. Hopefully he'll get some more money for to include paediatric sites, and it would be great for paediatric patients to know what their brain tissue oxygen tension is. So while I think we do need to add brain tissue oxygen monitoring to ICP and CPP, I think any success of this will really be in the context of something called multimodal monitoring, where we're also measuring cerebral blood flow, cerebral metabolism, and then the electrical function of the brain. Thank you. 17 minutes.
Thanks, Anusha. That was fantastic. Any questions? Got plenty of time. Yeah, Rajiv?
Look, I'm an adult intensivist and manage a lot of head injury patients in sort of adult head injury patients in our ICU. So I'm actually fascinated by this presentation. What I want to, because when I looked at in adults, we have worked together, we haven't found any data on the
Well,
adults?
in adults. Well, that boost study was in adults. I think that's the best information we've got so far.
And what's happening in Australia and New Zealand? You guys are doing a pediatric study.
No, so Andrew Udi out of, I think he's Melbourne, he's got funding for Bonanza, but only enough money to do 4 to 5 adult sites in Australia. So he was hoping to include paediatrics, but unfortunately he hasn't got the money yet, but he's hoping to get some more a bit later on.
Thank you.
Any other questions?
Anusha, I was just interested with the PO2 reactivity. When you put the monitor in, how much does the oxygen change when you turn up the oxygen?
Yes, it's a base law, about 200% when you're checking a normal probe.
In terms of where to put the monitor and if there's any asymmetry or variation in what you can see on the scan, how do you factor that in?
Well, I think there's no right answer. There's no consensus on where you should put the probe, but I think with the boost study, they put it in the least trauma-affected frontal lobe. I think CT confirmation is really important because you want to make sure that you haven't put it inside a contusion. That's the least helpful of those 3 scenarios.